Welcome, everyone. Thank you for joining us this afternoon. We are very happy to have you here to hear about our report on COVID-19. In a moment, I'm going to introduce the chairs of the working group who put this report together. But first, I'll say that this is a presentation of the Center for Intergovernmental Partnerships. Center was created in September of 2021 for the purpose of trying to improve relationships between different levels of government. So we've got a robust program planned for the coming months. And if you're interested in more information about it, please feel free to contact me. We'll make sure to put my email address in the chat, as well as my colleague, Miles Murphy. So with that, I would like to introduce Rich Callahan and Ken Kaiser, again, the chairs of the working group that put the report together. So Rich, over to you.
Nancy, thank you very much. And my thanks to the Center for Intergovernmental Partnerships and also my colleagues who chair the NAPA's Intergovernmental Standing Panel, Shelley Metzenbaum and Mark Pisano, who have been longstanding chairs of that. It's great to be here with you today and join my co-chair, Dr. Ken Kaiser, and the working group on the Intergovernmental Dimensions. Let me just share 2 slides with our audience this morning. And first is just to thank all the members of the working group who volunteered their time, 17 members with a strong representation from local public health, state public health. There's 5 former or current state public health directors that served on this working group, strong federal experience across a range of federal agencies on this, as well as others, 14 NAPA fellows and 3 outside experts who all volunteered their time, and you can find their full bios and their names in our report. Overall, the key findings of the group I would characterize, without going into detail in the 37 actionable recommendations. The working group, first of all, found that the intergovernmental system has been central to the response to COVID-19, not just any one level of government, but how those levels of government interact. Number 2, that there's really varied responses across levels of government. 3 is that there were 4 dimensions of the response that the group, working group focused on and identified as key. Testing, non-pharmaceutical interventions, vaccine distribution, and then overarching issues such as supply chain, data collection, and finance. And then 4, the group was particularly focused on developing recommendations that are actionable for performance for protecting lives in the face of the COVID-19 pandemic and into the future. So with that, I'd really like to again thank each of the volunteers, each of the members of the working group who volunteered for over a year to work together. For those in the audience, welcome any questions on chat. If you post them, I'll manage those questions. They won't appear to everyone, but please feel free to ask those questions. And with that, I'm really honored to introduce the co-chair and a driving force in moving forward with this, not just this report, but health in many dimensions across the United States, Dr. Ken Kaiser. Ken, to you.
Well, thank you, Rich. It's good to be with you all this afternoon, and let me echo Rich in thanking the center for helping to support this work, and to thank NAPA for convening us and getting us to the point where we are today. And of course, very deep and sincere thanks to all 17 members or 16 other members of the working group who contributed their time and effort to producing this report and to the rich discussions that we had over the past many months. So I'm going to shortly introduce the 3 other members of the working group who will make some comments. Before I do that, I should touch on just a couple of logistic things. First, I hope that this is a conversation as we have today. It's not intended to be a didactic presentation. We want to go back and forth and discuss some of the specific recommendations and some of the big picture recommendations of the working group. We have scheduled 90 minutes if we need to use that, but we certainly don't feel compelled to use all that time. We will take the discussion, to where it seems like a logical point. And if we don't use up all the time, that's fine. We're happy to give everyone back certain time in the day. As Rich noted, we will be managing questions through the chat. He will be following those and expressing them as we go through, either as we're going along with the presentations or the comments by others, or at the end. And I would also just in the way of a bit of an apology, I'm at my office, which is downtown DC, and it's unfortunately in a noisy location just a couple blocks from the White House. And so if there are sirens or demonstrations or other things, forgive me in advance for that noise. But let me just briefly introduce the other three members of the working group who will be making some comments. First will be Dr. Georges Benjamin, who is the Executive Director of the American Public Health Association. I've known Georges for a long time, and our paths have crossed in many ways over the years. Georges has a long background in public health and was in the military and has a wealth of experience to bring to the discussion today. Second will be Lauren Larson, who is currently the state budget director for the state of Colorado and works very closely with the governor. Lauren has a long career in state government and has held a variety of other roles in the past. She may have to leave us a bit early because the governor has said he needs her. So we'll see where we end up as to whether Lauren has to leave early or not. And then the third commenter is Dr. John Curlin, who is currently a distinguished professor of public policy and the founding director of the public policy programs at the McGeorge School of Law at the University of Pacific in California. Again, it's been my pleasure to know John for many years, and he has held a variety of other positions over the years, particularly focusing on environmental issues. And the longer bios for everyone is in the report if you want to read more about them. Let me just start with a few comments before I go to Georges. We first of all, in addition to thanking the working group members for all their efforts, just to put a little bit of context about the report, we really view this as a beginning of hopefully a much more extensive and longer conversation about the intergovernmental dimensions, not just of the COVID-19 response, but what we can learn from what has happened with COVID to how we address the next pandemic. I think it is a certainty that there will be another pandemic, probably sooner than later. It's not a question of if, but it's just a matter of when, and hopefully we can harvest lessons from our COVID-19 experience that will be beneficial going forward. As Rich alluded to, the intergovernmental dimensions of the response are really essential, and it is critical if we're going to have an effective response to a pandemic or other global health threat, that the different levels of government are working in sync as much as possible. I think the COVID-19 pandemic has given us a lot of experience to look at how well the different levels of government have worked together or not over the past going on 3 years now, and what we can learn to do things perhaps better and more efficiently next time. One of the other central issues that I think emerged from our discussions is the essentiality of trust in government if we're going to have an effective response to a pandemic or other global health threat. It is, I think, well known and well established at this point that over the past 10, 20 years or so, there has been a significant erosion of trust in government, in science, other areas that are essential to responding to a pandemic or other global health threat. And one of the specific recommendations in the report is that we need to focus on this issue of trust and trust in government and what we can do to regain some of the public's trust and understanding that that is essential to an effective response. We're going to focus, or the report focuses, and we're going to focus this conversation on 4 particular dimensions of the intergovernmental response. And I think to get things going here, I'm going to ask Dr. Benjamin to take 3 or 4 minutes to comment on, through his lens, his public health lens, of what he thought was perhaps most important, most revealing, most telling in our deliberations, or that came out of this report. Georges?
Ken, thank you very much. And hello, everyone. Let me just start by just saying that, you know, this was obviously a big event for both not our nation, but the rest of the world. But as we look back on it, it absolutely was not a technological or scientific challenge or failure at all. If anything, it was a challenge to the intergovernmental way in which we do things in the United States, the federalism, the partnership that we have with federal, state, and local entities, and how they work with one another, how they engage one another, who is authority to do what, how do they coordinate. And I think NAPA is the organization that since we do administration, can best think about what that intergovernmental entity is. And that's what this report tried to do. I think it certainly had not only the fact that the federal, state, local partnership was in many ways frayed and did not work as well as they could have, but then you add the fact that you have a global overlay to all of that, which makes it, of course, much more difficult to navigate. So in these 4 areas we looked at, focusing a lot on the fact that we really need to think about a much more robust testing strategy from a national level, leadership around prioritization and testing, and making sure that the lessons that we learned from this pandemic, we don't have to repeat again. It's going to be very important. The whole issues around non-pharmacological interventions. And we learned a lot about what to do. We learned a lot about what not to do as part of that. And the idea of picking up that science, and there's several recommendations there about how we begin to move forward on this from an administrator perspective. The fact that vaccines delivery as a very important commodity, and probably the most important prevention commodity, clinical commodity that we had, many of the lessons that we knew from public health simply were not implemented. The issues around equity certainly were not at the forefront of our activity around doing this. And then finally, you know, as we look at some of the overarching things, I think what we've done is in many ways raise the tent up and raise some issues that probably need to be dwelled in much further. And I still think that our nation needs to have a nonpartisan COVID pandemic commission to really get into all the weeds of this. One very much like we did after 9/11 as a way of taking reports like we've done here at NAPA and some of the other reports that have been done. There are lots of after action reports all over the place that have to be brought together. And having a commission that can look at those things in a meaningful, thoughtful way to address us further. By the way, this was a terrible, terrible pandemic, but it's not the worst one we could have had. And by no means, as Dr. Kaiser points out, it's not going to be the last one. Ken, I'll turn it back over to you.
Thank you, Georges. One of the things I'm going to come back and ask you about, as well as the other panelists after we've heard from them, has to do with our public health system in this country, and what we might be able to do to bolster it and strengthen it going forward. It has been pushed to the limit, and but we'll come back to that in a moment. Lauren, maybe you could comment on things from your perspective, certainly through your lens as the state budget director for Colorado.
Sure thing, Ken, and thanks for having me on this panel. I'll just open by saying how much I've learned being on this panel with a group of public health experts. For folks in the audience, I was there welcomed as the finance expert with, really not a lot of deep knowledge in public health. Over the past 2 years, I've just learned so much, and top of line at that is the incredible dedication and challenges that have been put on this community of practitioners over the past 2 years. It's profound, and I'm an admirer of your community. So thanks for having me here. From the, as an economist, as a fiscal leader, the top of mind for all of us here is how can our systems respond so we're never in a position again of having to shut down our economies to put the public health protections in place that we need to. And this is a critical piece of the after action look at this. And one of the big obstacles, I think, that led to us having to do some of the shutdowns was the failure or the problem, not quite a failure, but not being able to scale as quickly, not being able to surge in response with our systems. And finance is a huge part of that, because government finance does not surge quickly. In fact, all the structures and rules put in around it are to prevent it from surging quickly, because that is usually where we want incentives align, is holding down on our spending. Well, when you need to rapidly scale up, and it's not clear where that funding source is going to come from, what are from a state level, what are the federal avenues we'll be able to tap into, what are the state tools I have in my hands, and from a local government perspective, how are both state and federal helping to support and have a rapid response. So we, as a community of finance practitioners, found ourselves very much in the middle of responding to this crisis. To give you a sense of the scale, our emergency funds in the state were around 200 million in sort of liquid, fast things we could tap. They're meant for fighting wildfires and the like. Well, this, we've quickly spent over $1 billion in the first year, and now we're over $2 billion. So to a sense, an order of magnitude difference for the resources available for emergency response. So intergovernmental tools for rapid surge and are a key part of this. And we had some great discussions on the panel with that. I also would just, as an overarching theme, I'd talk a little bit about the role of financial problems in driving some of the inequities we see in our public health outcomes, and what this crisis pandemic has showed us is that typically we're dealing with advancing equity in equitable outcomes in public health through a disease-driven lens, right? There's a stream of cancer funding to fight cancer, or there's a stream of obesity funding to fight obesity, but there wasn't, at least in many of the states I'm familiar with, there wasn't a core funding in public health for driving equitable outcomes. And some of those gaps, when you have a crisis, when the pandemic hits, those gaps are exploited and exacerbated, and and we really want to fix that so that the next pandemic or the next crisis that we don't even see yet, we won't have those big gaps to exploit. And I'll be happy to looking forward to the conversation.
All right. Well, thank you, Lauren, very much for that. Several things occurred to me as you were talking, and one of the ones I probably was remiss in not noting it at the beginning was that many of our conversations over the past several months dealt with the equity issues and the importance of equity and the fact that there are profound inequities in our healthcare system and otherwise. We also know, and certainly in Colorado as well as in California and other Western states, we know that with these extreme weather events, that the folks who are most disadvantaged are also the ones who are hurt most, and that intensifies the inequities that already exist in the system. So maybe we can come back and talk more about that. I think one of the things that I was hoping that we would touch on later in the conversation is just how does government balance public health protection versus the economy, since both are essential, and that's perhaps some of the greatest tensions in dealing with COVID-19 has been the play out there as to how to balance what is the top priority, the protecting public health or maintaining the economy, or where do we find that right balance? So again, we'll come back to that later. But let me ask John Curlin to make some comments from his perspective about what you think, John, was most important or most struck you about the intergovernmental dimensions of responding to COVID.
Well, thanks, Ken, and thanks to Rich and all the members of the panel. I'm probably at least as far distant from the public health community generally as Lauren. Came at this with broad experience in looking at successes and challenges in public policies in a wide range of areas, but deep interest in what was going on here. And early on got attracted to issues of why we didn't understand what was happening, and why it was tremendously difficult for CDC, particularly as an organization, to mobilize and understand and act. And that fed into our long interest in data as one of the primary languages with which we talk about public policy choices and public policy implementation. There are really two main themes in that, two main types of dialogue. One is one that's observations, data, this is what I see happening. And one is values. This is how I assess it. This is what I would like to have happen. We have a lot of division on the value side in our community, and people also get selective about the data that they bring forward. In this context, it was apparent that we really didn't even understand the levels of infection, what the sources were, and that very quickly some of the dashboards which assembled available data weren't inside government, but was Johns Hopkins University notably. And then it turned out that the raw information wasn't available in the public sector. And so we had two news organizations going out and getting data, collecting data from the public sector, but at the county level even, and pulling it up and aggregating it. And that was the New York Times and the Atlantic. And they ended up doing that for months. And so how did this happen? I mean, we have a large governmental infrastructure. We have public health departments in every state. It is true that we haven't spent nearly as much money on public health as many would argue we should, and I agree we should. But the fundamental error, fundamental challenges in the data go beyond money, and they are expressed in the intergovernmental system, because the authority to collect the data and to do most of the significant decision-making around non-pharmaceutical interventions like mask mandate, mask requirements, and spacing requirements are at the state level, and they're implemented locally. And the CDC and the national level basically get data by permission if the states will pass it up to them. So it's an expression of our intergovernmental system, and it sits at the root of some of the data problems. The other fundamental problem about the data systems is that they are disease driven in most cases. And so a pandemic which came in, which had broad impacts on humans, and it was hard to sort out the particularities of COVID from the broad set of symptoms of respiratory diseases. I'm not a medical doctor, but I'm just reporting what I saw in the literature. That really was complexing. So it was a number of challenges about how to get the data and how to get them, first to collect them, and secondly, to make them available for use so that they were available for the decision makers who make them broadly available to the public, because the public was really interested in this and also frustrated by not understanding what was happening, and widely agreeable and accessible. So there's a problem in collection. There's a problem then in making it visible to the decision makers. And there's a problem in making it widely visible about data. And we really didn't do those systems did not work very well in COVID. They didn't work in understanding the disease. They also didn't work particularly well in understanding the capacity of hospitals to serve patients. They didn't work particularly well in making providing access to vaccines, which is another data system type problem. So there are lots of entry points on the data issues, and core to many of them are intergovernmental issues. There are funding system issues involved with them also. We have, if you look at the budget of CDC, it is very disease specific. There's very little directly to public health functions, and that it's really hard to get a system stood up for which there's not a day-to-day constituency just to sustain an effort. And pandemics blessedly come not every year, but when they come, they're serious events. We need to find a way to be able to respond to them. Let me just sort of end with a thought about what a good data system might look like. To the extent possible, it would be real time, so that we have data in time that is occurring today and yesterday and last week, rather than data systems that are 2 years old. We have data that what happened 2 years ago. Secondly, they need to be granular, as specific to individuals and hospitals and institutions and communities as possible. They need to scale, so they need to be robust statistically, not only at the national level, but the state level, but down to regional level. They need to be interoperable to the extent possible. So we have data on one system needs to be able to relate to data on another system, some common identifier like individual or location. This is a challenging task, but we have some capacity to do it. Some of it exists in government, some of it will be pulled out of other private data systems that are being collected. The promise of electronic medical records will help on some of this, and large providers, large insurers have data systems we ought to be tapping. We now know that we can sample wastewater streams and find information about infection rates. That can be done at the whole system level, or it can go down to narrower areas. We're probably going to bring new data systems into this. But the very sort of work, core work element and not very exciting issue of data is really critical for being able to build responses, to have an effective intergovernmental system. It's not going to run just on authority. It has to run on basically a shared understanding, and it's absolutely critical for trust. One of the things that happened that eroded trust in this system was lack of information and lack of knowledge. And if you can start talking about this is what we see happening, as opposed to this is how we disagree, you may build some more trust over time.
Thank you, John. Your comment about data is not very sexy, but it's absolutely critical if we're going to have an effective and an evidence-based response. Just couldn't be more true. And it brings back, in my mind, both your and Lauren's comments to many conversations I had with the governor of California when I was director of health for California throughout most of the 1980s, and managing the HIV epidemic at that time, as well as putting in place a statewide cancer reporting system and a birth defects monitoring program. Of course, after talking to the governor about how valuable these would be to public health and how important this was, his question was always the same. It's how much it's going to cost and what am I going to get in return for those dollars. So we'll come back to some of that, but all of the comments I think have touched on the public health system, our local and state public health systems and the federal counterparts. And we know that the system has been really stressed by COVID, indeed stressed to the max. Several hundred local and state senior public health officials have either been fired or resigned out of frustration or for other reasons. And we know hundreds of other health officials, local and state health officials, have also gone elsewhere. And it's not just health, but in education and in other areas as well. But Georges, I wonder if you could comment a little bit, particularly from where you sit with the American Public Health Association, as to where do we go with our public health system in this country? What do we need to do? What are some of the actions that we really need to move forward with so that we're better prepared to deal with the next pandemic?
Okay, thank you very much. Let's start with as recognizing, I think as John pointed out, that yeah, we have a public health system on paper, but it is basically a system that has grown up based on what people wanted to do on any particular day, depending on what someone wanted to fund. Not usually enough, not usually completely, and not usually with the intention of it actually doing the results that we expect of it. The public believes that they have a comprehensive system, and we do not. It's extremely porous. Some of it's money, some of it is alignment. But I think one of the biggest things we have to do is make sure that we, for once and for all, take a big sheet of white paper and say, okay, we want to have a public health system in our country. Going forward, what should it look like? And design it for the future. Many of the things that John said are things that we should have. But let's take the data system as an example. In an environment in which everybody else in the world has interoperable data systems that share data all the time, whether or not you want to get a car at 3 o'clock in the morning in a neighborhood, anywhere in this country, and certainly in the urban setting, whether or not you want to send and buy something from your couch, almost anywhere in this country. We don't have a data system like that for public health. You can, in many cases, can't even move an electrocardiogram information across the street from one entity to another. Sometimes even between entities that are connected. So just building that data system for a system that's data-driven would go a long way. It is going to require money. It is going to require a good system design. There is an effort at the CDC to lead that effort with the Office of National Coordinator. But the truth of the matter is, it's got to be a moonshot type of effort to build that system in a way that is effective and responsive to the needs of the people that have to use the data. Secondly, we have to deal with the workforce. We do not have the workforce that we need. We have lost over 40, 50,000 public health workers over the last 10 years. But the last estimate is that we need over 100,000 bodies to actually do that. So it's a jobs program. There's no question about that. A professional jobs program. There are many people that want to go into public health. Schools of public health are bristling over with students that want to be trained in public health and could go in. But there are barriers. Local governments have got to be willing to hire them. There has to be money to hire them. And they have to be paid at a salary that is competitive. And that also has been an issue over time. And I think finally, so data workforce is very important, but I think foundational to public health is making sure that we have, public health does its work based on policy. And we need to make sure we're clear about what the legal authorities and responsibilities are for public health. Turns out a governmental public health entity is the only entity in the community that has the legal responsibility for the health and well-being of the community. And we have to treat them the same way we treat the police, fire, EMS, and our military. And in terms of funding, that funding has to be enough, but it also has to be sustainable. So our nation has a tendency, in fact, not a tendency, we do this every single time. Something bad happens, we throw money at it, sometimes a lot of money, but not long enough and often not enough. And then we take the money away before we finish the job. And let me just say, quite frankly, Congress is doing that today already, not finishing the job. So we're repeating the same mistakes as we have before. But I think that's kind of the framework of some of the things that we need to do to build that system. And by the way, we know what to build. There have been numerous reports, and to do this, we just have to roll up our sleeves and have the political will to do it.
Thank you. Great comments. And I know Rich has a question that he wants to pose in here from one of the members of the audience. Before we do that, though, I wanted to go to Lauren to get a comment that, you know, as important as the federal health agencies are, as well as the local public health agencies, in our form of government and our federalist approach to things in the U.S., the states are always going to be key and have a particularly important role in managing health issues. Now, coupling that with the observation that you always know what's most important to an organization by looking at their budget. So how do we, Lauren, how do we get public health and the importance of public health reflected in our state budgets going forward? An easy question, right?
Yeah, Ken, I do think that this after action study is a, you know, sort of a seize the moment time for looking back at that ROI question you mentioned, the discussions you had in California. And this, because from where I sat, it just seemed a no-brainer where our brief shutdown had us burn through our general fund reserves in 90 days. You know, in compared to the small dollars we were spending on our public health system, it was just a massive hit to our revenue stream, all of our revenue streams in a very short period of time. And so from the trade-off from a fiscal office perspective, it was just a no-brainer. Like, okay, we have to fund what we need to do to keep our hospitals, make sure there are beds in our hospitals. And that became sort of our North Star metric, right? What was happening in our hospitals, which was a data, to John's point, we didn't have transparency in number of beds. That was, a big problem. And then what capacity did our institutions have to surge to keep things out of hospitals? Could we do the testing and the treatment, the therapeutics, do all of that outside of ERs so that we could keep our ERs open and not have to take these dramatic steps that have such economic consequences? So I do think from the state, we could see that we had a unique lens to look across multiple jurisdictions and see what some common tools and requirements might be. We're working on a legislative package right now around hospital readiness and some key standards that we want all the institutions to be able to meet to be sure we can surge as needed. But I also saw limitations. For example, when we were having to surge and needing more nurses to staff the staffing contracts, there was like crazy price gouging going on across and states competing with each other. And this happened in the PPP wars in the early days, et cetera. So there are some things from even in our federal system where I think a national perspective that that can prevent some of that local government and state government competing for the same resources. There's, you know, some policy options that would be beneficial to be explored there. So how to build more into the state budget, I don't know. Those are my first things top of mind.
All right, well, thank you. And John, I'm going to ask you to weigh in on, but first, Rich has a question that he wanted to pose to the group.
So appreciate Barbara Dyer's question, and it is addressed to primarily to John, though George's, you might want to comment as well. Barbara asked, how large is the gap between what John presents as the ideal and what's real now? And what would it take to get there? And the third part is, how did Johns Hopkins emerge as the reliable source of information, and what can we learn from? I think that's best left to one of the panel members, Josh Sharfstein, who's not here, but who's Vice Dean at Johns Hopkins School of Public Health. So on those first two questions that Barbara asked, the gap and what would it take to close that gap? John, do you want to respond?
I'll start. And maybe I'll mention Johns Hopkins also, although it's not my university. The gap is large, but it requires money. But the primary thing I think it requires is imagination and rearranging some expectations and some organizational roles. Let me first start with the last about organizational roles. It's not in this particular paper, but I've continued to do work on this set of issues, and I've become convinced that it's going to be extraordinarily hard to get an organization whose base of funding and scientific competence and organizational culture is disease focused to really do public health work. And I just described CDC, which is in its funding and its personnel, and its organizational structure and organizational culture, disease focused, and yet it is the major public health institution. So that's a huge challenge. And I'm not certain you can, in my mind, organizations typically do one thing really well and other things sort of not as well. So I think we need to find a way to unpack how we think about public health and possibly re-envision something that is a different structure. Because in the absence of clarity of authority, clarity of funding, it's going to be very, very hard to do this. That said, it's very hard to maintain focus and funding streams without an ongoing constituency which is clamoring for the money. And I heard there was a piece where 4 directors, past directors of CDC, were talking about this, and Director Gerberding was talking about the difficulty in trying to increase flexibility in funding, because every one of those dedicated disease funded streams was unwilling to allow any flexibility. So that's the nub of the problem. There is an organizational design, political dynamic that is central to this. If you get past that, then the data issues become. We have a much better technology. We have much better ability to collect data. The other major barrier to good data that comes out of the science and orientation is a research orientation, and we have to get the data cleaned up and perfect, and that just doesn't happen in a real world setting. And it's actually not even the legal standard for policymaking, which is best available data. And when I was involved in executive roles in the natural resources doing work in the state of California, I worked hard with scientists, and it was always a real task to get, we need what you understand today, because it's going on the agenda, you know, and we're noticing for a meeting, we need to pull this together. So there is that, but I think it's a doable. I haven't done pencil to paper, or I haven't talked to people about dollar amounts. I actually don't think it's orders of magnitude more money than we're spending now. I think a lot of chunk of it is reimagining what we're doing. And we just in the period of COVID went to requirements for labs to report, all labs report electronically. That's happening now. It's going through the states to CDC. It doesn't go directly to CDC. But lab data is only part of what we need. We need more than that. That doesn't get us the hospital capacity data. But we set up systems. Systems were stood up to do that. Those need to be sustained. And so a lot of this is doable, but a lot of it is political hard work. It's real political.
Thanks,
Yeah,
John.
let me add to that. You know, if you think about the fact, the need for a single patient identifier. If you go on, I'll use Amazon again. If you go on Amazon and you buy something from your office, and then you go home and you buy something from home, Amazon's not confused about who you are. If you go to a doctor in one office, and then you go to a doctor in another office, they don't know that you're both George Benjamin. Okay? There isn't a single place where that data comes together in our health system. When you look at what Hopkins was able to accomplish, they have a preparedness center which is dedicated to really doing this kind of work, but they were able to build on that system they already had to get data. But it wasn't just the data system that Hopkins had. The federal government didn't have the modeling capacity, but the University of Washington in Seattle did. They had it because they had a phenomenal investment by a foundation for a long period of time and the freedom to actually build the models. Now, CDC has now been funded a little bit of money to begin to build a modeling system at CDC, but you know, it's not going to be enough. And the question is, will they be funded over time? Tom Frieden asked for money for us to do the kind of genetic analysis and cataloging of viruses and other infectious microbes when he was a CDC director. Eventually, he got a little bit of money to fund it, but it by no means of a system as robust as the Brits had when COVID hit. And they were able to have a big, robust system. So, you know, systems are designed to do exactly what they are designed to do. And we have not designed the system, adequately resourced it, and then had the performance expectations of the system. If we do that, I think as John says, while there is a gap, a substantial gap, but it's not as big as people would think. And I think the more important point is, I think as Lauren pointed out, if we don't make this investment on the front end, we're going to spend enormous amounts of money and heartache on the back end. And it's not just for this outbreak, but it's for the next pandemic. It's for the next major public health emergency like a tornado or a hurricane. There are many other bad things that could happen that we are not yet prepared for.
So let me, these comments have prompted several thoughts about data and elsewhere. And I did also want to make a plug for the National Quality Task Force, which incidentally was convened in 2019. I co-chaired that. And of our, the report came out in early 2020 and kind of got drowned out by COVID because it came out right as COVID was hitting. But the number one recommendation out of the National Quality Task Force as far as where healthcare quality should go over the next decade is to have a single identifier, a single patient identifier. It's absolutely critical foundational piece to moving a lot of where we need to go in healthcare data forward, and indeed just to improve the quality of care, so all of the data gets back to the patient. So let me go back though to where we were talking about public health, and I think Lauren, your comments highlight one of the challenges here in that particularly, in a situation like COVID, the attention is on hospital capacity, emergency department capacity, and taking care of the sick people. But public health does a lot more than that, and much of what they do is behind the scenes. So I would actually ask all of the panelists if they would weigh in on how do we get the attention focused on the less visible but critical part of the healthcare system, i.e. the public health part of it, which often deals with things like data and immunizations and preventive care and things which are often hard to garner the headlines the way it is when you have people backed up in the emergency department. But it's actually that infrastructure and having that public health system in place is critical to dealing with any of these health challenges going forward. So who wants to jump in?
Can I, I'll just spin off that because I'll go back to, this feels like a seize the moment time when the connections are so obvious of how that backbone work, that ability of a public health agency to hire up quickly, put testing contracts in place, or run their own labs, scale up their own labs, how that actually ties immediately and directly to what's happening in your broader health system, in the hospitals and the economy. And it's so obvious right now. It's it seems ripe for action when it's fresh in everyone's minds, when you can see that direct connection. And we had a couple successful budget requests last year even to do this, to put permanent funding in place. And it's, a precious dollar of general fund is a rare thing to find in our Colorado state budget, but we put general fund, and the legislature agreed that having this backbone in our public health agency so that it could scale and have a response in a way that could keep things from impacting the larger economy, like that just what resonated. It was bipartisan. So I think this is the time, it's a season moment, and it's drawing the picture and diagramming out how those core functions can't be starved and they can't be disease specific, so that we can, because they are tied directly to outcomes, to keeping the whole health of the state of the nation healthy.
John, any words of wisdom? You're muted.
I actually want to go back to something else and talk about the necessity to reimagine. The Johns Hopkins site was a scraping site. It collected no new data. Its genius was to take available data and visualize it in a way that was accessible and keep it up to date. If you compare that, the CDC had nor to California. I don't want California, Ken knows California much better than I, but none of these systems had sort of leapt forward to what was technologically possible. This is the imagination part. Now, I also want to say that site, though, turned out to be, I think, and similar sites that focus just on infections and deaths ended up being pernicious, because they drove the dialogue to simply a disease focus and the infection, the COVID as a disease. But COVID had many other impacts, and CDC had data on some of those impacts. CDC had data on emergency room visits. They had behavioral data from their surveys. So months later, they start to pop up data on suicide ideation, on real suicide data, because that vital statistic data also. But meanwhile, over here, our big dashboards are only showing infections and deaths and hospitalizations. And those are humans who are being affected by the disease. And those were part of the manifestations of the experience. But we got by our media and by all the the impulse in political systems to focus on one thing and one issue, and then we had single individuals up talking only about this is an infectious disease that was experienced in society by individuals much more broadly. And haven't yet talked about the impact on education and on the economy. It lost about 3/4 of 1 year's GDP. That's a big hit. We have people whose educational careers, from what we know about education, is lifelong impacts from being closed out of schools. Still ongoing debates about how the impact of NPIs and real robust debates about how effective these were. But when we had our dashboards were dominated, as I said, by the scrape data about infections, hospitalizations, and deaths. Too limiting, really a challenge. I think we need to find a way to open it up.
Can I, having that data would have made a lot of difference in our response. We would have made different decisions if we had thought about some of that stuff.
Yeah, and you got to get the rest. You got to get a broader set of data about humans and about societal impacts up and visible. So it can't just be the disease in a narrow sense. The disease is driving a lot, but it's never, the impacts and the responses are never in that narrow window, or shouldn't be.
I want to come back and pivot the conversation a little bit, but I also feel compelled to, I join the others in applauding what Johns Hopkins did as far as the data, but they weren't the only ones. And I think we've alluded to this, but University of Washington, their health metrics folks, and there were others that also produced very good and actionable data that was key to the response to the pandemic. One of the comments that Rich made at the beginning that I want to come back to was not just the essentiality of the intergovernmental response, but the essentiality of addressing multiple issues concomitantly at the same time. And indeed, our report focuses on 4 of these, the testing and vaccination and NPIs and data. And all of these have to be dealt with at the same time if we're going to have an effective response, which is, I think, a lesson going forward is that how do we balance these multiple balls at the same time, because the system and our attention tends to be focused on single issues. But responding to a pandemic or other global health threats is going to require both a multidisciplinary response and balancing multiple balls at the same time if we're going to be effective. So with that as kind of context, Georgia, let me come back to you. And how do we, as is typical with any disaster or major situation like COVID or the COVID-19 pandemic, there's going to be a lot of reports afterwards, lots of reflections, lots of Monday morning quarterbacking, whatever metaphor you want to use, but looking at it and trying to harvest lessons about how we can do it better going forward. This report from NAPA is one step in that regard, but how do we put all of this together in a way that we actually do harvest those lessons and better prepare the nation to deal with not just the next pandemic, but these other global health threats that are looming on the horizon. So George, why don't you start, and then I'll ask Lauren and John to weigh in on that as well.
Oh, yeah, thanks, Ken. Yeah, there are a couple of proposals out there for a bipartisan commission, again, just like the 9/11 Commission, to really get the facts out there in a nonpartisan, factual way. And then I think as part of that commission's work, they should help us prioritize. And they should help us prioritize which areas we need to focus on first, knowing what the challenges are. And as you know, a lot of times things as John pointed out, simply need to be thought differently as part of that process. So I think that would be the first step. And then from a response perspective, of course, you and I practice emergency medicine, and we know you have to triage, and you cannot do everything. And you've got to do the first things first. Some of those things are foundational that you have to do first. And I think that is one of the challenges we're going to have going forward, is that we have to do these things in a thoughtful way, but we also have to make a commitment for the long haul. That means long-term funding commitments. That means a view of being sustainable. That means being flexible in what we do. We can no longer have systems where if you're funded through funding stream A, and in the host of an emergency, the people who are doing work on infectious disease A or chronic disease A cannot help on chronic, on the response. And right now, our funding situation is set up that way, which prevents you from doing that. And that means that some of our smartest brains have got to figure out how we do that, but at the same time, maintain the accountability that we have in our systems, because a lot of these things are put in place for fraud, abuse purposes. But we can figure that out. And there are other models in other places that have already figured that out. And other nations, by the way, do parts of this quite well. And we ought to emulate and learn from some of those other nations' work as well.
Lauren, any thoughts?
Yes, I think to the Angelides Commission, even more than the 9/11 Commission, and the dissection of the financial crisis, and all the warning signs were there about the systemic risk, the interconnectedness of the financial system, and the analogy here being the interconnectedness of the public health risks. So it's picking a few top goals and aligning efforts at the local level, at the state level, and the national level is key. Is that having not the data system that's going to be the be all and end all for everything, but where can we start with collecting and getting a big win on something that could have a big prevention impact down the line on the data side. On the finance side, having some permanent sustainable funding sources so that every local and state must have this sort of backbone infrastructure, and I'd expand that. I'll even say, hospitals and pharmacies and other systems have a backbone in place to enable our country to surge when we need to surge. And then just keeping this basic organizational design principle that Professor Curlin is so eloquent on, where, if it's not clear where you have, maybe the lines and the structures right now of who's in charge of what doesn't work going forward. And we should rethink that. Where do we need more, just like when we were relooking at the banking system, the way the mortgage-backed securities market was all kind of external and not as regulated as the regular banking system. We need to look at sort of bringing what things need to come together so we have the right organizational lens to be more responsive and prevent a pandemic from hitting so wide.
So John, you've worn many hats over the years. How do we bring all this together so we can focus and triage, prioritize, do the things that have already been alluded to going forward?
It's a big challenge, and I think to add, I think a national commission or two or three actually might be useful. And right now, a lot of money's been thrown, is already being appropriated to be spent on these issues. And as Georgia said, it's likely to be a one-time infusion, but it's just on the data issues I've mentioned. It's at least 500 million, and at least 1 billion, excuse me, in CDC, specifically the data, plus a bunch of other things, and I have no sense of how that money will be spent. But I wanted to to change, and I don't know who the audience is to this. I think the National Academy can play a role. I think this intergovernmental group could play a role. But if improving the performance of some of the key organizations is really clear, really important, and I think everything we can do to make any public health organization work better is important. The other way to think about this is system resiliency. And one of this, and I want to mention two papers that were in this thing, which are examples of that. One was the use of waivers, 1135 waivers on Medicare. Basically, the healthcare system was stood up. Was basically its capacity expanded by waivers and an infusion of money. And amongst the waivers, the telehealth, which got congressional authorization also, but then relaxations on the ability to practice across state, and nurses could move, et cetera. Didn't increase the pool of personnel, so Lauren ran into competition problems and bidding up and stuff like that, but allowed people to move around, and that helped. So increasing flexibility actually improved capacity. The other example of an idea in this working group is John Bartran's on supply chain, where instead of thinking about just a static reserve, instead increase the capacity inside the ongoing system. So that in the idea of every hospital should have 60 or 90 days of PPE built into their supply chain so that they just have it. Now that's a drag, we're so used to thinking about just in time and efficiencies, but in the context of thinking about resilience, that's probably a cheaper solution than what we did. Now that doesn't get you the flood of PPE you need when eventually you need it, but it spreads out and it gives you a chance to increase capacity. So thinking about these design features, not from a single organization, from a system organization, back to that then though, you need sensing, you need data. Data drives a lot of that. You need capacity, you need imagination, you need people who can let go of what their organization narrowly can do and say, this is something new, we need to find something else. The place in the federal system that has ability to surge money is the federal government, because they have the big debt capacity. They did a big splurge on vaccine development. They did a tremendous amount of money flowed out in the variety of acts. And I don't expect Lauren and Colorado, Lauren specifically wrote a big check to put something in the general fund for Colorado to build capacity. I think every state should be doing something like that. But in our system, the feds have the money and they have the capacity, and that's going to be the place that the fiscal capacity is going to get. So I don't know where that ends, but I think I would shift to thinking about it as a system rather than single organizations.
Great comments, and I want to just circle back. I mentioned the National Quality Task Force before, and their recommendation about a single patient identifier. Among their 10 recommendations, two others that you just alluded to out of the COVID experience had to do with telehealth and making that a normal part of both the reimbursement system and how we move forward, but also moving towards national licensure of healthcare professionals. I mean, there's a long history of state licensure, and I understand the dynamics and the politics associated with that. But I think it's become increasingly clear that there's one standard of care across the country, and that there's a lot of reasons why it would make sense to go to a more singular licensure across the U.S. But that's I'll save that topic for another day. In the interest of time, since we're winding down here, I mentioned at the outset that one way of thinking about the COVID-19 pandemic and our response to it is, in many ways, it's a rehearsal for some of the global health challenges that confront us due to climate change. Given where things are, it seems pretty inevitable that we're going to get to that 1.5 degrees of warming of the climate, and that many of the untoward consequences of that at this point look pretty inevitable, which has a host of global health challenges associated with it. So what do we take from our response from COVID and apply it not just to the next pandemic, but to these other global health threats that are looming on the horizon? George, do you want to take a stab at that? And then I'll ask Lauren and John as well.
I remind us that we just have lots of, I mean, the world is just full of infectious diseases and agents that are changing each and every day. Viruses produce millions of copies of themselves when they mutate, not just one. And all it takes is one that is opportunistic enough to be infectious enough and maybe lethal enough to start another pandemic and crowd out the one that we have. We have climate change, as you mentioned, Ken, that's out there. But at the end of the day, almost all of these health threats require a system to identify when a new health threat comes into the community, the ability to coordinate across all three levels of government and with the private sector to provide an effective response, and then to build a firewall so that the next time it happens or something like it, the impact is much less. And I think as we look at our report and we go forward, we've tried to put together something that raises the red flag and tells folks, look, we don't have this system yet. We've looked at it from a systems perspective, and we can point fingers as much as we want. But at the end of the day, until we build that kind of system that rapidly identifies threats, addresses those threats in a comprehensive way, we're still going to be vulnerable. And that's for the things that are not, overtly man-made. The things that are indirectly, like a changing climate, that ultimately at the root of it is influenced by man's activities, is something far different. But no matter what we do, we have to be prepared to respond.
Yeah, and Ken, let me just jump in. I want to share with the participants in today's conference or panel, if the recommendations that George are talking about in the report, they're really geared towards being actionable. And so as George was talking about testing and knowing of a threat at the front end, there's recommendations on that. There's recommendations on the workplace. There's recommendations on vaccine distribution and on these overarching issues. So I'd encourage people to take a look at the report and really see how much of this discussion is put and is operationalized in the recommendations. So I turn it back to you, Ken.
Thanks, Rich, for pointing that out. Let me just ask Lauren and John if they have any comments really on how we design this system that we need going forward to deal with the future health threats that are looming. I mean, it's no longer a matter of if they're going to happen, but we're going to have to confront a variety of global health threats going forward, pandemics amongst them. And we really need to have a system that is prepared to do that. So, and we don't have it today. So how do we get there? Lauren?
Well, that's a big question, Ken. I think George just gave pointing us in the right direction. And as Rich said, we tried to be really actionable in this report about pandemic related. But when I think about lessons from this report that I would lean to answering this bigger question, the equity work comes to mind about what, in the gaps that we know now, about why some populations are harder hit by when there is a disaster, when there is something striking. And that is a systems issue that we don't want to just fix disease by disease, disaster by disaster, but there's some fundamental things that are broken there in our country. And maybe thinking about that equity work through that lens of, okay, there's a range of possible future crises, and how do we shore up this, how do we close these gaps so that we, are sort of not exacerbating the problem as we go forward. So that was one thing that comes to mind, where we could link those two questions.
John, any thoughts? And then we're going to try to wrap this up.
Not much. Well, I've from the earlier comments, I would look at this as system resilience and try to figure out things. And I was reminded that I'm a farmer also, and that we have a whole set of institutions focused on trying to identify pathogens that are plant and animal based and come in and screen them and control them. That's a lot of similarities. And then like many people right now, I've been trying to understand military conflict at a level I didn't try before, and another set of intelligence systems to try to maintain and understand threats. So I think one thing I might do is just say, this is a world in which there's lots of different types of threats, and we have as humans, again, sort of compartmentalize them. But can we identify ways in which we learn about those threats and respond to them across these systems? Now, I don't know, but some of them are very similar in the agricultural world on plants and pathogens are very similar to the sorts of disease things that we're talking about in the public health world. And I would some of the response systems are going to be the same. We're finding that we have tremendous interdependence and dependencies on flows of energy and natural resources and real value conflicts over how much we should be seeking independence, et cetera. So we can have those conversations, but these I see a lot of similarities in these issues, and I think that we can pay attention to them and learn across the choices, across the different things we're now separating.
And Ken, let me just jump in with a question from Maria Ristigata, who's the dean at the Biden School at the University of Delaware, who brings it very much in the present, where she asked, we're seeing evidence that COVID's not over, as we're seeing spikes of a new variant. Is there something we should be doing now to prepare the public for the next wave? And I think you've touched on that, but I just want to surface that question as well, Ken.
Yeah, I mean, the short answer is everyone needs to get vaccinated. We still haven't reached the levels that ideally we would be at to prevent this, and we haven't seen the end of COVID. As you say, there's more to come, but certainly the evidence at this point seems pretty clear that the best way we can protect overall population health is to make sure that we have a high level of vaccination across the population. George, you want to add anything there?
Yeah, I've argued that as a nation, we have to begin thinking about what are the potential threatening trajectories of this particular outbreak. Clearly, there are three obvious ones. One, obviously, this thing changes to something that's much more infectious and much more lethal, which requires a new vaccine, new testing tools, et cetera. And, that's a potential. That's not likely because they don't usually change on a dime, but it's possible. And we need to prepare both our systems and the public for that. The second one is that it looks kind of seasonal, kind of comes every year, once or twice a year. And we need to be prepared for that particular eventuality. We need to prepare the public by talking about that as one of the potentials. And the third one is what we're seeing right now, episodic outbreaks, kind of look like little measles outbreaks, 15 people here, 20 people here, a couple of 100 people from a big dinner. We need to prepare for those as well and tell people what our testing strategy is, what our remasking strategy is, what is our social distancing strategy, and have operational plan so that the public doesn't get, quite frankly, freaked out every time they hear about a new outbreak that's occurring. And I think, as Rich said earlier, it's going to require a fair amount of really ongoing, very clear communications to the public on an ongoing basis so that people, I don't want to normalize this, but we want to make sure that people aren't afraid and that they respond in a thoughtful manner every time they hear an announcement that there is a new outbreak. People know exactly what to do. And that's something that is our future. And we need to build what I would argue is a preparedness society so that people are aware of how to handle this new world we're living in. And by the way, this new globalized world we're living in is much more dynamic and has many more threats. And we're just going to have, quite frankly, to learn how to live with them. But we have tools. And the good news is we have tools. The bad news is we don't necessarily use those tools as effectively as we ought to. And I agree with Ken, at least for right now. The new secret is the old secret. Get your shot, get vaccinated. It will save your life.
All right, we are actually we're close to that 90 minutes. I didn't think that we would actually go this long, but Rich, are there any questions in the queue there that we need to try to answer quickly?
No, there's not questions in the queue, but a couple points. One, just want to point everyone's attention to Phil Cooper's post in chat where he lists the social equity lens for COVID-19 action. That's posted and he prepared for NAPA. I also want to, Lauren, thank her, and she's off to the governor is called. But also we really want to thank Terry Gerton and NAPA. I think this report really illustrates the great strength of NAPA. Terry is the executive director. Kyle Romano has been instrumental in helping us finalize the report, and Caitlin Blum from the NAPA staff in helping us get started. The report really illustrates a great strength of NAPA, which is working across the different levels of government, bringing together practitioners, researchers, academics. We have 4 or 5 former deans or current deans serving on this working group. Really, NAPA's focus on social equity and health equity applied in this is important. So just wanted to say how this brings us together, and we'll look forward to working with the Center for Intergovernmental Partnerships and Nancy and NAPA on following up on one of the questions of really how to continue to have NAPA spark a follow-up and action on this. So I want to convey my personal thanks to Ken Kaiser when I reached out, we talked early on, and to each of the panel members today, Georges and John and Lauren, and thank all for this significant and important contribution.
Thank you, Rich, and thank you for all of that you've done to bring this report to fruition. And thanks to John and Georges and Lauren for participating in the panel today. Thanks to all of the working group members, and also thanks to the National Academies for making this happen. With that, I think we can call it a day and look forward to our further conversation on this really important topic. So thank you all.
Thank you all so much.
Thank you.